And good morning. It is June 12th, 2024. I'm Dr. Deuk Majan, CEO and founder of Deuk Spine Institute, along with Arias Deuk Majan, who's here today as well. He's not in the operating room. Another founder of Deuk Spine Institute. Our first patient for the day, and we have 4 surgeries today that we'll be broadcasting. She's returning. She has thoracic pain at T11-T12 and T12-L1. She has 3 discs that are damaged on MRI in that area. We're choosing the 2 that we think are causing her pain. There is another one that's above that could be, but she didn't localize her pain to that area. She also has sacroiliac joint pain and facet joint pain at L5S1. Now, she originally found us because she had an artificial disc put in at L4-5 at another place, not here. We don't recommend them. And Jordan, let's show the artificial disc. That artificial disc started to pop out, and the surgeons in her area were not very helpful. So she contacted me, and we did what's called a salvage procedure, where you try to fix the problem and you basically do a fusion. So she got a fusion done here, and she was very happy. It went very well. All right, let's go up. Now, to do the thoracic disc repair, we have to identify the proper levels, which we have. It is going to be the 12th rib. Jordan, show us the 12th rib. Right and left, 11, 12. Good, that's the 12th rib. And that will take you right back to the pedicle, which is the circle there of the bone, the vertebral body, of number 12. So that's 12. That means the bone above is 11. And you can see the disc is compromised. And you can see there's a bone spur off to the left side. And we're going to be treating the T11-12 disc from the left side. So that's the first one I'm going to get into. And let's go ahead and take an x-ray. All right, so that's the needle is now at T12-L1, and we're going to put it at T11-12 first. We have any numbing medicine?
Yes, sir.
I'll take it. Remember that, oh, I meant skin. The T11-12 we're treating on the left side. She's having bilateral thoracic radiculopathy, so pain radiating around to her ribs on both sides. So we knew that she needed a solution on both sides. Turns out that at T11-12 it's worse on the left, and that at T12-L1 it's worse on the right. So we're going to go on 2 different sides, left and right, so we treat both sides' radicular symptoms. All right, shot. Nice. So when you do this procedure, the Deuk laser disc repair, we first have to get into the disc to repair it. And to do that, we use a needle. And the needle is guided by X-ray guidance. All right, so let's see here. Let's count down. Let's go down and find the fusion. Just not too far, just a little bit. Shot. All right, so there's the fusion. You can see the artificial disc popping out in front of the spine there. Jordan, show us that real quick. Artificial disc popping out. It's supposed to be further back, but it's slipping out. That's why we don't do artificial discs. They pop out. All right, so then there's L4, L3, L2, L1. Just bring the fluoro north a smidgen there. Let's see what that does. All right, 4, 3, 2, 1, 12, 11. So my needle is behind the pedicle of T11, right? So it's a little high. Let's go north again, just a small amount. All right, that little dot, that metal dot is in front of, let's see, 4, 3, 2. So the little button is in front of 2. So let's go north a little bit. Shot. See, the button moved, right? So you can't rely on it. Now the button is at 1, 2, right? Moved up. So you got to be careful what you use as landmarks. That's why the spine is always the best. All right, so if that's 2, that's 1, that's 12, that's 11. My needle is still behind the body of 11, and we want to be at 11, 12 on the left side. So I need to aim it down a little bit. And I think that's all I need to do. I think the entry point is fine. I just have to aim it down a little. Shot? Yeah, that's going to work. So our entry point is perfect. When you're doing these types of procedures, where you enter and where you end up, those are your beginning and your end are very important. And everything in between is important as well. But you've got to pick the proper entry point and the proper target. So start and end. All right, I'm feeling the facet joint, which is exactly what I want. I'm going to sneak around the facet joint. I could feel it. I'm going to sneak around it. And this is called needle jockeying. And this is why they call the pain management docs needle jockeys, because they got to jockey the needle around nerves, muscles, bones. And so I'm a neurosurgeon who does some needle jockeying. All right, I'm not able to get around it, so I got to figure out what's wrong. Let's get an AP view. And it may be that I'm too medial. Some patients have scoliosis, their spine's twisted, so you won't see that as well on the lateral view. You got to change your view and just see where you are. You got to, there it is. So I'm too medial, okay? I need to be just a little bit more lateral, about 2 millimeters, 3 millimeters more lateral, and I should be fine. Again, you can see the needles at T11-T12 based on the ribs. All right, so I'm going to go a little bit more lateral and see if I can to do it. There it is. All right, I think we did it. There we go. All right, perfect. Again, you want to be as medial as you can be, but you have to get around the facet. Shot. All right, we're on a perfect trajectory at this point for that disc. Shot. Now remember, T11-T12, there's still a spinal cord here. So you have to be very careful. Most surgeons won't operate in the thoracic spine for this kind of surgery because the spinal cord is there. They can injure it and the patient will have problems. We've learned how to do this surgery properly so that we don't have those kind of problems with our patients. Now she is not under general anesthesia. She's under conscious sedation or twilight to where she can respond and tell us, you know, if we're, yeah, you're doing great, lay still. Because I'm going to need her help in a minute. All right. Yeah, lay still. You need any help up there? All right. One nice thing about the endoscopic procedures is that there's virtually no bleeding. Ah, that's why. So what happened was my stylet, which is this thing in the middle, was pushed back and the needle was not advancing because it was no longer a needle, it was like a biopsy needle. So there we go. That's perfect. I'll go a little bit more. All right. So the beauty of this technique is that you use a minimally invasive, in this case a needle, approach to the spine rather than cutting her open, which is what most spine surgeons will do. Let's put pressure here. Okay, she's got just a little bit of venous bleeding. All right, now that I've got left T11-T12, I want to do right T12-L1. So I'm going to, did you already put numbing?
Yes.
So we're good. We're going to go on the right side. And again, your entry point is massively important. And this comes from my experience doing spine surgery. But if you're off, say by a millimeter or two in certain places, you can really hurt the patient badly. And it will be a permanent problem. Okay? So I make it look easy. And I don't talk too much about where I start, where I enter, because it's a long discussion, but it's also kind of proprietary information. All right, so I'm happy with 11-12. I need to get into 12-1. And for some reason, my approach angle does not appear to be optimal. So I'm going to try to see if that can correct. Maybe it's just parallax with the X-ray machine, because I should be at a good entry point where I'm at. Let's see here, Jordan. Give me a second, Sean. AP? Any questions from our audience?
At this moment, no current questions.
Let's show our audience how a disc injury can cause so much pain. Hitting something. All right, welcome back. Now you can see why disc injuries cause so much pain. It's all due to inflammation. And the inflammation is coming from an area of the disc in the back of the disc called the posterior annulus. Posterior means back, anterior means front. This is the posterior annulus. Yep, thank you. And we're still navigating our needle into T12-L1. We're going to be there in just a minute. Shot? Where do you feel that? In your back? All right, we're almost done, I promise. So I need the patient awake to help guide me to make sure I'm not getting too close to a nerve, for example, because, yeah, you gotta fix that. I'm just hitting the back of the vertebral body. So I want to go up a little bit. Shot? And this is that jockeying we talked about last time. Shot? Yeah, I need to be a little bit higher up. So I got to reposition. Shot? 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 All right. Shot? Yeah, that should be it. Okay, we're almost done, I promise. All right, good. So we're in. So the needle does several things. One, it allows me to create an entry point and a target, connect them together in a safe trajectory so I can pass a dilator and then a tube so I can do the entire surgery through a corridor, what's called a surgical corridor, safely. How long have you had pain in your thoracic? Huh? How many years? 50 years. Wow. 15 or 50?
50. Yes.
Wow, poor thing. She suffered with thoracic pain for 50 years. Is that a long time? Damn right it is. And it's affected her quality of life for 50 years. That's why she's having this surgery, folks. She wants a better quality of life, but it's sad that life can be ruined for 50 years. I mean, if you've ever had pain, you know what it's like. I mean, we all get pain, right? And thank God it's quick and it goes away quickly. But imagine having it for 50 years and you have to watch every step, everything you do. That's how powerful pain is. It can control your life. And at Deuk Spine Institute, we can eliminate pain and give you your life back. All right, are you comfy? See that? You hear her? How bad is that on a scale of 1 to 10? How high did it go?
What's the number? 8.
The highest it was an 8? Is that where you get your pain? Perfect. So she had 8 out of 10 pain on the discogram, and it was concordant, meaning concordant just means that's where she gets her pain. Is it better now? Congratulations, we found one of your painful discs. That's the T11-12. All right? We're going to get rid of that pain forever. You see that? She tightened up. She's saying, ah. How bad is that on a scale of 1 to 10? 8? You know there are numbers above 8. All right, so we got 2 8s. 8 out of 10, 8 out of 10. Is that where you get your pain? All right. You're going to go to sleep. When you wake up, that pain will be gone forever. Congratulations. So folks, first of all, no doctor treats thoracic pain because they don't know how. Second of all, if they did know how and they believed it was coming from a disc, they still won't treat it because it's too risky and they don't know how to treat it. At Deuk Spine, we pioneered the first thoracic disc treatment for pain, and we've been performing it now for 6 years. We've done about 35 patients. We did one yesterday. He came from Puerto Rico. His pain is 100% gone in his thoracic spine. You're going to see a testimonial from him when Henry gets done editing it. But this is the most successful treatment in the world for thoracic disc pain, and we're the only ones in the world that do it. So if you're having thoracic pain or you know somebody with thoracic pain, send them here, because we got 2 discs. We're going to eliminate that pain. Remember, she came to me because her artificial disc was popping out. We fixed that. Now she's back because she has thoracic pain. All right, we're going to get started. First thing I'm going to do here is I'm going to make a 7 mm. No. 4.
You want to start going?
Yeah, I say 4.
I need a 7 with this.
What do you think? That's pretty collapsed. Let's try a 4. We have 2 scopes. We're just talking about which would be best. And either one would work, but I think we should do the 4. We're going to do the 4 millimeter scope. Okay? Give me a second. So I've made the incision. Take your time, guys. We always have things we can talk about. We're going to start with the left T11-12. And like I said, the great news is that we just confirmed through discography that these 2 discs are the source of her pain. Now, she has a 3rd disc we're not treating. It's higher up here. But she really wasn't complaining about pain up here. She was complaining about pain right here. And how do we know? We do a special test before surgery where we ask the patient to point to where their pain is. We identify where it is, and we put actually paper clips and tape it to your skin, and then we do an x-ray. It's really quite simple. And that shows you where the pain is coming from on the x-ray. You can't do that with an MRI, but you can do it with an x-ray. All right, simple test, very cost effective, and highly accurate and assisting in the diagnosis. So let's get started. We're going to remove the needle, guide wires there. Okay, now that we have the guide wire in, we take the needle out. Now we're going to place this dilator. Look how small this is. This is about 2.8 millimeters wide. It's going to slide down this guide wire, and it's going to basically separate the fibrous tissues. So remember, your skin is a continuous tissue layer, right? You have to cut it with a scalpel. But past the skin, everything else down there, subcutaneous tissue, fascia, muscle, connective tissue, all of it is fibrous. So it's kind of like your clothing, right? You got cotton fibers in your clothing. If you look at it with a microscope, you see little fibers. And we're going between the fibers. We're not cutting the fibers. Now, any other type of spine surgery, they're cutting the fibers with a scalpel. And that's why there's the need for post-operative narcotics, because the surgeon is just chopping you up inside, cutting all your fibers. So there's lots of bleeding and pain and scar tissue as a result. With this procedure, there's no cutting of any fibers. We're just spreading them apart. And when we're done, they're gonna come back together. All right? All right, so we are now just getting into the annular tear. Now, some people ask me, Dr. Deuk, aren't you causing damage going through the annulus? No, we're going through the tear that's already there. So there's already damage. You ready? All right, guide wires out. Now I'm gonna advance this dilator into the disc. See how the bones are separating a little bit? Because see, this is even hard to get into, Luis. See that?
I see that, yeah.
And the other thing is, I think she has a little osteoporosis, so I didn't want to, yeah, it's just better to go smaller. We don't want to fracture it. Yeah, this is tight as it is. All right, so we're in with our dilator, and we're going to bring our tube. The entire surgery is going to be done with this little tube. You guys see this? This is like one of those coffee straws, right, Henry?
Yes, we do. Yep.
And we're going to put this over the dilator. It's going to go into the tear also, and it's going to sit with the end of it right in the herniation. We're going to use a laser then to clean the herniation and tear. We pioneered this technology right here at Deuk Spine, Arias Deukmajian and myself, and we published it 12 years ago, well, actually more than 12, 14 years ago, first time. We've been performing this surgery now for 18 years here at Deuk Spine Institute. Shot? All right, so you can see the tube is coming down over the dilator. Henry, let's show the audience, how does the Deuk laser disc repair actually work? What are we doing in there to get rid of pain?
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
All right, welcome back. You can see from our video, is irrigation going? No. You can see from our video that the Deuk laser disc repair is a procedure that identifies endoscopically the source of pain, which is a tear in the disc. And that tear becomes inflamed. And you know what inflammation looks like? Take a look right here down the endoscope. That's what inflammation looks like. It's pink and red, and these are fragments of herniation that are causing the inflammation. The body's response is to try to get rid of this herniation and seal the annular tear, but it cannot, because the herniation fragments, these little chunks right here, are stuck, keeping the door wide open and keeping the inflammation going. All right, you can see it's calcified. That means that it's been there for a long time. You know it's calcified. You see the golden colored stuff? That's what happens when the laser energy is transferred to the areas where it's calcified, is the calcium becomes oxidized and turns a golden color. So that is calcified herniation that you're seeing, and scar tissue and fragments of herniation. So we have fragments of herniation, which are these chunky things that are floating up. We have scar tissue. We have calcium. And there's some annulus fibrosis still left, not much, and there are these bone spurs like right there. Okay? So we're going to clean out all the things we need to in order to get this disc to become pain-free and heal. Any questions?
Yes, we have a couple questions. This first one coming from Rita on YouTube.
Hello, Rita. You're our #1 fan now.
Yeah. They ask, good morning, Dr. Deuk. Are you not worried that other surgeons are watching your surgeries and that will try to learn and do your procedures without you?
Thank you, Rita, for your concern. No, I'm not worried. I know that I make these surgeries look really easy, and I appreciate the fact that you would think they are easy to do, but they're really not. I'm a very highly trained neurosurgeon, and I went to the top neurosurgery training program in the world, and I personally would never try this surgery on my own after watching a YouTube video. So if I wouldn't do it, and I'm a pretty aggressive at trying new things type of surgeon, but anybody else would not do it. You know, most neurosurgeons will not do new procedures unless they're properly trained and get a certificate, okay? So to do that, they're gonna need to come to me and spend a year probably, and I'm just saying a year because on average a year, but every procedure has to be individually taught and assessed, their skill level and preparedness, and then given a certificate. So I'm not worried about it at all. This is not something that you can just pick up from watching videos. You'll kill patients if you try it. And they know that, I know that, you don't know that, but they know that. Trust me, they know that. So they're not just going to do that. Yeah, I've been broadcasting these surgeries, Rita, for 10 years. You know how many surgeons have started to do the Deuk laser disc repair that I'm aware of? 0. So if they haven't picked it up in 10 years, and we've even published this, peer-reviewed and published in PubMed. So we've tried to raise awareness. I've given talks on it at national meetings. The top neurosurgery meetings in the world, I've given talks. I've been invited to speak over the years, all over the world, and still they don't do it. So I've done everything I can short of developing my own residency program and fellowship, and they don't. And the reason they don't, by the way, Rita, is not because they don't want to. I mean, actually, they don't want to. That is the reason, okay? These surgeries are very hard to get reimbursed from the insurance companies. That's the God's honest truth. So the surgeries that these surgeons are doing are fusions and artificial discs. Much easier to get paid for those, and they get paid about 10 times as much as I get paid for each surgery, okay? So the reimbursement for the surgeon is 10 times higher to not do this surgery, but to do fusions and artificial discs. That's an average number, obviously. So there's no financial incentive for these surgeons to do this surgery. The only incentive would be to do better care for the patient. And these surgeons are not usually motivated to do that. And I know that because I've talked to them, taught them in lectures about this procedure, and yet they're still not doing it. So there's an old saying, the proof is in the pudding. And if they're not adopting this new technology, even though the proof is obvious that it works, then there's got to be a reason. So what is the reason they don't adopt it? And the reason is because they're making too much money doing fusions. That's why. And it's a broken system. And that's why we broadcast to patients. Number one, we want people to know there's hope for their problem. We can fix it. And number two, we want people to know that there's a better treatment available to them other than what their surgeons are offering them. Safer for the patient and better. All right, next question.
Next question coming from King Smooth on YouTube.
King Smooth, welcome.
Asking, can facet joint syndrome and cervical stenosis cause thoracic pain?
So the question is, can cervical facets or stenosis cause thoracic pain? The answer is 100% no, cannot. I mean, obviously, if you have a C7-T1 cervical problem, which connects to the thoracic, then you can have an upper T1 thoracic issue, but otherwise, no. A cervical problem will not cause thoracic pain. Your best bet, my friend, King Smooth, is to get an MRI if you don't already have one, and go to our MRI review form, fill it out, and get a Zoom meeting scheduled with me. They are free. I will meet with you. I'll look at your MRI. Do you have a grabber?
Yes, sir.
And I will tell you exactly why you're having thoracic pain. And if I can't, and you need additional testing done, I'll tell you what you need done, okay? But I hear that all the time. So many patients are misinformed by either their doctor or, you know, some source, nurse, therapist, whatever, chiropractor, where they're told
Thank goodness.
that they need this treatment in the cervical spine to fix the thoracic, when that's not true. All right. Next question.
No current questions, but we do have a comment from Rita once more on YouTube
All right, Rita.
saying, "No, I don't think it's easy. I'm worried for others. Others aren't like you. That's why I'm trying so hard to get to you. I do know that there are doctors who don't have the patient's best interests at heart like you."
Yeah. Thank you, Rita. Yeah, I appreciate you saying that. We at Deuk Spine Institute, we're able to do any surgery in the world there is to do on the spine. But we recommend to our patients the best. And some people like to criticize and say, oh, you guys just do endoscopic laser surgery because you don't do fusions, you don't do artificial discs. The answer is we do. And if you go to our YouTube channel, you can watch me do those surgeries. I've done them in the past. I've done 1,000 fusion and artificial disc surgeries on the neck and another 1,000 on the back. So I have the experience and I have the training, I have the ability to do any spine surgery. The reason we choose this one is it is the best of all of them. And I want my patients to get the best. Wouldn't you want that for your family? Any other questions?
Yes, we have a question from Mixing It Up on YouTube
Mixing it up.
Yep.
Thank you. Nice to you to join us.
asking, "I'm currently recovering from a third discectomy in the last 14 years, all from disc herniation at the L5-S1. Do you think
Grabber.
not doing a fusion is a mistake? I'm a 40-year-old male from a small city in Canada. I just don't trust the surgeons available to me to perform a fusion."
Mixing it up. First of all, you do not need a fusion. I guarantee you. Okay, we can fix you without fusing you. You need the Deuk laser disc repair. The reason you've had 3 discectomies is because the microdiscectomy laminectomy procedure that is being recommended and done on you does not fix the problem. The problem is the tear in the annulus. Hello, laser. The tear in the annulus cannot heal with a microdiscectomy because the surgeon is not cleaning the tear like we are right now. You see us doing this with the laser. The surgeon cannot see inside the tear because they don't have an endoscope when they're doing a microdiscectomy. Microdiscectomy and discectomy are done without the endoscope. They're done with just looking down at the spine, and you can't see anything as a surgeon when you're just looking down at the spine. You just stick an instrument down there and you grab around, but you're not actually cleaning the annular tear. And so because you're not cleaning the annular tear, the disc will never heal. It'll never seal itself off. So you're going to keep getting herniations over and over and over again, okay? And that's why you've had to have 3 of them done, because the disc never healed properly. If you come here, I will clean your disc with this laser right here like I'm doing now, and your disc will heal and you will not need a fusion. Now, if you, for some reason, do need a fusion, which I could say 99% chance you don't, then I could do your fusion and get it done outpatient in 2 hours. And you'll go back to your hotel in 2 hours. You'll be very happy, all right? But I'm 95% sure you don't need a fusion, my friend, okay?
Thank you.
I hope that answers the question. Now, Henry, will you post our free MRI review
Of course.
link so that patients, people watching can get our free MRI review?
Already have? Yep. Not a problem.
That's the best thing to do, is to get a free MRI review. At least that way you'll get answers to what you need done. We don't charge for it, and you get 10 minutes with me at no cost to you, except for your time. All right. Just about done. I need another minute on this disc. We are at the back of the disc. I'm just trying to get the last few pieces. For those of you who don't know, this is a type of surgery that's very unique. We pioneered it here at Deuk Spine. Now, it uses two things that are highly unique. One is the endoscope, which is what you're seeing the disc with. It's a camera system and a rod lens system that allows us to look inside the disc, as opposed to looking at the disc from the top down, where you can't see inside. Okay, so this gives us the ability to see inside the disc and find the problem areas and fix them. Second of all, we're using a laser. And the laser is that blue thing you're seeing at 12 o'clock, and it's got a little glass fiber coming out. That's a optical fiber, just like they use for the internet, you know, across the Atlantic Ocean or across the ocean. They lay these fibers. You know, you hear about fiber. Oh, I need fiber. That's optical fiber, okay? We're using the same type of fiber to transmit, instead of, Google to your house. We're transmitting laser energy made from a machine that's at the patient's, in the operating room by the patient's feet over here. It's a big machine. It's the size of a large suitcase. And it produces laser energy, and we need to transfer the laser energy from the machine to right here where I'm using it. And that's done with a fiber. And this fiber is around 8 feet long. And we can reuse it after one patient. We sterilize it and use it again. Okay? Keep things cost effective. And so what you're seeing is I'm moving this fiber around to deliver energy to different parts of the disc in order to treat it. Now, when the laser energy hits these disc parts, it literally, the tissues absorb the energy, and it's too much for them to hold, so they just blow apart. So we call it vaporization. It literally vaporizes the covalent bonds that are between molecules, like carbon molecules and nitrogen and carbon, and breaks them apart. So these proteins just literally blow apart. Their protein chains break apart with laser energy. All right, I think we're done with this one. I'm going to irrigate a little more to get all the pieces out, but I think we're at the back of the disc. Let me just check. Yep, we're outside right now. We're looking at the tear. There's a little bit of inflammation. You see that? That we want to get rid of, okay? That's where the pain comes from. So I don't see any more areas of inflammation. There's a little bit of calcium there, a little calcification, but we're done. We're done. That's perfect. All right, so we're done with one disc. We got one more to go. I'm going to irrigate this out, and then we're going to move on to the second disc. But we already know this is one of the discs causing her pain because we tested them with the discogram, called an evocative discogram. Any questions?
No current questions, but we do have a couple comments. This next one coming from Rita, once more on YouTube, saying that someone I know went to Europe for a dynamic fusion that was just FDA approved, but in Europe they did for the last 12 years. I still don't want any parts put in and my pain just taken away. One day, hoping.
All right, just take a look at this incision, and we just did the surgery through. Let's get a tape measure. Yeah, thanks, Rita. There's no such thing as a dynamic fusion. It's a bullshit procedure, by the way. Fusion means you're fusing bones together so they don't move anymore. All right? Dynamic means there's movement. So it's a, what do you call it? Oxymoron?
It's like jumbo shrimp.
No, yeah, like jumbo shrimp. Right. No, that's a bad analogy because there is jumbo shrimp, but it's like the big little, or the little big. I mean, it's stupid. And the way that they came up with, I got to get through here, and I can't get through here. Okay, you guys need to be thinking ahead and having these areas prepared for this transition. Okay. It's like saying I got the hot cold. I mean, it's just fusion means you're fusing bones together so they don't move. Dynamic means there's movement. The way they came up with this whole dynamic fusion is surgeons that did fusions they kept moving. So they called it a failed fusion or a dynamic fusion. And now it's turned into something sexy that's marketable. And that's the only thing it has is market value to the name. Sounds sexy, dynamic fusion. But it's absolutely ridiculous. There's no such thing as a dynamic fusion. It's a failed fusion, a fusion that didn't take. Now, the people who had fusions that didn't take were usually smokers or people with osteoporosis who couldn't make fusion bone, and they ended up with scar tissue instead. Now, it turned out that those patients still got good pain relief, so we started to realize you don't need fusion in order to get pain relief from an area that they're trying to fuse. Of course, this doesn't apply to trauma. It's just degenerative stuff. So when it comes to degenerative spine conditions, now their companies are saying, hey, look, patients like this stuff. They like the idea of a fusion that isn't really fused. So let's start selling it. Okay? Anyway, I would never recommend a dynamic fusion. You don't need it. You need the Deuk laser disc repair. That's all you need. Wait, shot. All right, we're about to get into the next disc. Go ahead. There's so much hype and nonsense in spine, unfortunately, because there's a lot of money. There's tens of billions of dollars available in insurance payments, and everybody's out there with their hands out, their hat out, you know, trying to get that money, even though it doesn't help the patient. And it's supposed to help the patient. We're going to change that. Deuk Spine Institute is literally going to change the way the entire world sees spine care. And hopefully the way insurance companies pay for it eventually. My long-term goal is to help get the insurance companies on board. We're going to save them billions of dollars a year by providing patients with treatments that actually work, not dynamic fusion garbage. And you certainly shouldn't have to go overseas to get good spine care. It should be here in America. All right. We are inside the T12-L1. And we're going to fix this one. We'll be done. We're going to end the broadcast, and then I'm going to come back and we're going to restream for the sacrum. We're going to do a bilateral sacral Deuk plasma rhizotomy to treat SI joint pain. Yeah, and L5S1 facets as well. All right. Any questions?
Yes, we have a question from Mixing On Up once more on YouTube.
You got it. Are you going to?
Asking,
no staples.
So 2 weeks post-op, do you think getting this procedure without an existing herniation is beneficial?
2 weeks post-op. No, first of all, you have this Deuk laser disc repair when you have pain from a disc, okay? And then you have a tear that hasn't healed. So I would not recommend surgery unless I've seen you on Zoom and I've seen your MRI. Okay, we're just talking theoretically here. But in theory, if you're still having pain, then you need the Deuk laser disc repair. If your surgeon told you you need a fusion, then you need the Deuk laser disc repair. That's easy. But to find out exactly what you need to do an MRI review with a telemedicine Zoom call with me, which we do every week. We do 100 of them. And at that point, you'll know what I'm recommending. You'll know what it's going to cost and what the success rate will be. And then you can decide if you want to get it done. But I can tell you right now, if somebody's telling you need fusion, you don't need a fusion. You need this procedure instead. And yes, there is a herniation there. You just don't see it, or they're not calling it on the MRI. For those of you new to our channel, if you go back and look, you'll see that we have thousands of surgeries streamed from beginning to end. There's no other hospital or clinic or surgeon in the world that does that. We're the only ones. The reason why is because they don't want you to see their mistakes, their bad outcomes, their bad results. We don't have mistakes and bad outcomes or bad results, so we just show you everything. We want you to see the truth, number one. Number two, we want you to see how good our results really are and how good they can be. Now, you're not going to get these results with other surgeons or other places. You're only going to get them here at Deuk Spine. How do I know? Because I know what other surgeons do. I used to do what they did. It doesn't work. That's why we stopped doing it. Okay? And, you know, most people don't understand this, but you're watching literally a top trained neurosurgeon in the world perform surgery. So it's not like we're some Mickey Mouse club that's just doing some surgery nobody else does. We know how to do all surgeries that all surgeons do. We don't do them because they don't work as well as what you're watching. I know it's hard for you people to understand that, but go back and watch the hundreds of testimonials of our patients and you'll see what I'm talking about. And by the way, other surgeons don't have hundreds of testimonials of patients from their surgeries that have been cured of pain because they can't cure the pain. It's that simple. Otherwise, they'd be showing you those testimonials. Do you believe for one moment the Mayo Clinic wouldn't show you hundreds of cured back pain patients if they had them? Of course they would. Do you believe for one moment the Cleveland Clinic wouldn't show you hundreds of testimonials of cured patients, or the Rothman Institute? The answer is they don't have those patients, therefore they can't have those testimonials. We have those patients and we have their testimonials. That's what separates us. You're not watching an inferior spine center, you're watching the best in the world fixing people, and that's why we broadcast what we do. We want people to see that there is hope for them. But it's not everywhere they can get fixed. It's Deuk Spine. So when you talk about that there's no herniation, you can fix my disc pain, of course I can. I know what I'm talking about. If you were recommended for a fusion, that means there's a problem with the disc, right? Because they wouldn't be doing a fusion if there wasn't. And if there's a problem with the disc, this is the surgery you want, not a fusion. Now you can go get a fusion, and then when you get in pain again afterwards, you can come see us, or you can see us before you get the fusion. The choice is yours. Or you can just live in pain if that's what you want to do. Frankly, I don't care. What I care about are the people who are smart enough to realize what we're doing is the best in the world, and they come here and they get treatment. They're called my patients. And I actually like my patients. I love my patients. Because my patients aren't just my patients. They're smart people. They're people who have figured it out. And the people who aren't my patients, well, they're dumbasses as far as I'm concerned. And they can go suffer. And you can say, oh, that's so mean, Dr. Deuk. Yeah, it's mean. The world is mean. Life is tough. Get used to it. Life sucks sometimes. But it's going to suck a whole lot worse for you if you don't come here and get fixed. That simple. We have any other questions?
We have another question. Two questions. One from Rita once more on YouTube. Asking, why did the FDA approve dynamic fusion? I would never. I was just saying what I was told someone did.
Rita, the FDA does not approve procedures. Think about that. Let it sink in for a minute. The FDA, Federal Drug Agency, approves implants, metal, okay? The FDA does not approve indications for treatment. The FDA will never say, oh yeah, you can use that because it works. The FDA only approves things based on safety, all right? So what happens is I could say, I'm selling this rod that I'm going to stick in your eyeball and it won't cause blindness and it doesn't do any good for you, and you can run it through all the tests and show that it doesn't cause any damage, but you stick a rod in the eyeball, it doesn't do any good either, and the FDA will approve it. All they're looking for is safety data. So does this device harm the patient or not? And if the device does not harm the patient, which, by the way, the researchers could fudge those numbers, and they do all the time, and they give it to the FDA. I mean, you know, if you know the director at the FDA and you go out to steak dinners with him all the time, or her, whoever it happens to be today, then you have a special relationship with the FDA, and you can get things through the FDA approval process quite easily. Point is, all they're looking at is safety data, okay? They don't look at efficacy. They don't look at indications. So you can get the FDA to approve all kinds of things that don't work. I mean, I wouldn't, personally. When I say that everything we do is FDA approved, it is. Every drug we use here for this surgery is totally FDA approved. Every device we use, including this endoscope, totally FDA approved. The laser, FDA approved. Now, I didn't go out and get FDA approval. The companies that sell these things did. But this laser is useless for the spine if it's not used the way that I use it, which is endoscopically. So just having a laser FDA approved doesn't mean it works. Having a laser that's FDA approved used with the FDA approved endoscope, that's the magic. And that's what we discovered at Deuk Spine. Arias, Deuk Machen, and myself.
We have another question
Sure.
coming from FL Sandy Toes on YouTube.
FLC Toes?
FL Sandy
Oh,
Toes.
Sandy Toes. Yeah, we've heard from Sandy Toes.
Of course.
Welcome back.
They said 69-year-old female diagnosed with degenerative disc disease since 2006. Now I've been on Fosamax for 9 months. Do either of these disqualify me for your treatment? Pain is almost unbearable now.
Listen, Sandy Toes, you are a perfect candidate for our treatment. Perfect. Because you're on Fosamax, which means you have osteoporosis, which means your bone quality is not good, which means you should not get any kind of hardware put in your spine at all. And you should not let surgeons take bone out of your spine because you need your bone. So our procedure removes no bone. It does not destabilize your spine at all. So it's perfect for osteoporotic patients like you. I heard a new noise I've never heard, which is crinkling plastic from a candy wrapper behind my ear. That's how attuned a surgeon is to their operating room and the noises that are made. One of my staff was popping a candy in their mouth way behind me, and I heard the wrapper, and I thought, do we have a water leak? Do we have a IV fluid leak? Do we have an electrical current on the floor buzzing around our feet? No, it was just a candy wrapper. So osteoporosis patients are perfect for the laser surgery, and the fact that you're 69, we've operated on 95-year-olds, no big deal. We just have to get medical clearance from your doctor to say you're safe to have surgery, which is not a problem usually. And you just need to get over here and get it done. My advice, do our free MRI review from the comfort of your home. Henry is going to post that link if he hasn't already done so. And you just use that to fill out a brief questionnaire. Where is your pain? How long have you had it? Does it go into your arm, your legs, whatever? Probably your back is what we're talking about. By the way, there's a piece of herniation. Very scarred and calcified, so it's dense. It doesn't want to come out. It's really hard to float it out. So I've got to break it up a little more, make it smaller so it's not as weighty and it can float out. Okay, or I can grab it. Here it comes. There we go. See what I mean? So some of these herniations have been around a long time, so they're very heavy from calcification, from chronic inflammation. You're the perfect candidate. We could fix you. Come to us. Let us fix you. Thank you. By the way, it's very interesting. Arias Deuk Machen, who is going to be heading up and running Deuk Spine Institute someday. He's also going to be a neurosurgeon. My son. He and I did a project, a research study, that we looked at patients who had chronic back pain that showed up for treatment, diagnosis and treatment. And what was their diagnosis? Well, guess what? The number one cause for chronic back pain was disc injury, like these discs right here, okay, causing pain. And that was 86% of primary pain, 86%. The second most common cause of chronic back pain was the facet joints, FACET joints, and they accounted for 8%, 8% of chronic back pain. That's primary cause, like that's the number one major cause, right? And then after you look at all causes of back pain, because patients who have disc pain, a lot of them also have facet pain, and a lot of those also have piriformis and SI. So it turns out that the average number of pain sources, the average patient is about 4. So it's not just one disc or 2 discs. And the problem is a lot of spine surgeons only treat 1 disc or 2 discs at a time. And so these patients have 4 pain sources, which means you go get treatment, you're still going to have pain. At Deuk Spine, we make it our top priority to first diagnose the source of pain or sources. And some patients have more than 7. Actually, 20% of our patients had 7 or more primary causes of pain, and that we diagnosed it on their examination. So my advice is do your Zoom call for free from home, and then once we know what's wrong, we'll tell you and we can fix it, and then you can come get it fixed, all right? That's the best way to do it. It's very convenient. That way you don't have to sit in the doctor's office waiting to be seen and getting angry because we're 2 hours behind, which happens, by the way. We are behind. We're almost done here. This disc is very different than the last one. The first disc, the T11-T12, was much more collapsed and dehydrated. This one is not quite so dehydrated. There's still a lot of nucleus that has hydration, and that's why it's taking me longer to get all these little fragments out. But you know, some discs are quick, some are long, and the important thing is that you fix each one and do whatever it takes. All right. Any other questions?
Yes, we have this question from Sue on Facebook
Yeah. Hi, Sue.
asking,
Okay.
how long after the acute phase of disc injury would you consider it reasonable to consider DLDR if L5 to S1 have been damaged and trap sciatic nerve?
Sue, that's a really good question. I appreciate you asking. So, Sue, I'm going to answer your question, but it's going to be kind of with the reasoning, okay, behind it. The answer, in my opinion, is 2 weeks, but it's not that simple, all right? So I'm going to qualify my answer. First of all, if you have a pinched nerve, there's, let's just look at the situations, all right? There's a herniated disc with just back pain. There's a herniated disc with back and leg pain. There's a herniated disc with just leg pain. There's a herniated disc with leg weakness. All right? Leg weakness, leg numbness, which is neurological symptomatology, neurological compromise. So get that, it's very important. So there's back pain, there's leg pain, and there's neurological compromise. If you have neurological compromise, such as a drop foot, weakness with your foot, I wouldn't wait 2 weeks. I'd get it done right away, like immediately, within 24 hours. That's going to give you the highest chance of full neurological recovery to get your strength back. We all know that as neurosurgeons. We used to take patients with an acute drop foot in the hospital. They came into the emergency room. We'd take them to surgery that night. It's emergency. Why? Because we knew as surgeons that the sooner you get the pressure off the nerve in an acute situation, the higher the chance of recovery, of function for the patient, you know, getting his strength back. Nobody wants to go around life with a foot brace the rest of their life and not able to run and enjoy life and sports. And besides, when you have a drop foot that's permanent, it's going to cause orthopedic problems like your knees, your hips are going to start going out because you're bad walking and posture. Okay? So if you have weakness, you want surgery right away. If there's no weakness, then 2 weeks, I think, is a good amount of time to wait. You could try an epidural. I'm not done. I'm not done yet. You can turn the light off. I'm not done yet. If 2 weeks would be a couple of minutes. Yeah, this is a longer, just taking me longer. Yeah, so I hope that answers your question. Here's the problem. Let's just say, you can disagree with me. It's fine. You can say, well, I've had friends, they waited, a month and the pain went away. Yes, it went away, but it's coming back. And that's what I don't want you to have, is I don't want my patients to have the pain go away and then come back, because that's what's going to happen. If you have back pain from a herniated disc in your lower back that lasts more than a few days, then that injury is going to be there and it's never going to heal properly. And you're going to end up like this lady, 50 years later, suffering for 50 years, quality of life sucks, and eventually getting it fixed. So my advice, invest the money now, invest the time now, get it fixed now, reap the benefit, which is, many, many years of great life quality, of enjoying functional activities and being independent of pain meds and people having to take care of you. Look at that annular defect, guys. That's the hole where the herniation came out of, right there. Okay? That's annulus fibrosis right there. And that's actually normal annulus fibrosis. This is the torn part. Okay? And there's still a little bit of herniation there, but we're pretty much done. So we're going to end the stream, and we're going to be back in 10 minutes with our, no, less than 10 minutes, 5 minutes, with the bilateral sacroiliac joint DPR. Okay? Thanks for joining us. Any other questions I should take before we go?
No current questions.
Awesome. All right, we can go ahead and end the broadcast because we're pretty much done, and come back and we'll be doing a bilateral SI joint DPR, Deuk plasma rhizotomy, a treatment that's permanent relief, developed here at Deuk Spine Institute and patented at Deuk Spine Institute.